Let's start today our medicine class with a disease of renal system. It is called CKD. It is a disease of kidney which is irreversible and long-term disease. Long disease of kidney, and where the kidney lost its normal function. So it is called chronic kidney disease. Different causes are there for this disease, and it's very common, becoming common day by day because of hypertension, diabetes prevalence. This disease is now increasing, and we have to know how to manage as an internal medicine specialist. Also those who are nephrologists, they learn it and how to maintain the disease. So it's a big chapter, CKD. You have to know all of different kinds of reasons how to you will diagnose it, but today I am going directly on the management of this disease very shortly, precisely for exam purpose. Okay, so big thumbs up, please subscribe the channel and learn more and more about the medicine. So at first what we will do, number one, we will monitor the renal function. Very important in this CKD. It's a long term disease. For many years this disease will deteriorate. So our target will be to monitor the disease. And how you will monitor? You will monitor by different investigations related to kidney. But what is the time to monitor? You should monitor in every 6 months. Those who are in stage 3 CKD, but those who are in more stage 4 or 5, or condition is deteriorated, it's getting worse, those patients, those persons should be monitored more frequently. It may be in each month, it may be in 2 months, according to severity. As a doctor you found, in that way we will mention it. Now how will monitor? There are different investigation. I am not discussing here, I am only for managing purpose. I am telling that you will do monitor the renal function. Secondly, for monitoring purpose, you should make a graphical representation, a graph where you will plot the eGFR against the time, and for many years you will predict, you will plot the eGFR level with the time, and you will see the changes in the changes of the level of GFR, and can predict about the progression of the disease. So now we should, after monitoring, the second option should be to reduce of the progression. You have to, as it is a progressive disease, you have to reduce its progression. How you will reduce its progression? Very easy. You have to treat the primary cause. You have to find out what are the reason of this chronic kidney disease. You have to give treatment of that. Easy. Secondly, you have to control the blood pressure. So if you control the blood pressure, then the progress of the CKD will be reduced. Thirdly, you have to treat or control that proteinuria. Okay, you will control the proteinuria. Now for BP controlling, the target, our target, those who are from diabetic nephropathy, their DN, there should be target that 130 by 80, below that. But in case of only CKD, no albuminuria, its target should be less than 40 by 90. Okay, so this should be your target. You may use different kind of antihypertensives. to control the BP. Okay, now important drugs. Now in proteinuria I will mention a drug like ACE inhibitor or ARB is used. It can both reduce the blood pressure, and even if BP is not increased but there is proteinuria, you can use this drug. These drugs are very much important to reducing proteinuria, and there are some target there are when you can use it. It is told that if proteinuria is more than protein in blood or proteinuria, it is told that PCR is more than 50 or ACR albumin creatinine ratio that is more than 30. Okay, 50 30, ACR 30, PCR 50. Now when this is the condition, if you use this drug, it will definitely help. Okay, now the problems of ACE inhibitor in ARB, those drugs have some problems when you should stop it or you should be very much cautious. Some small point: if you are having sick, you are like having vomiting vomiting, okay, or fever, any hypovolemic state, you should stop this drug, because that time what happens, it reversely will damage your kidney more. How will it cause the damage, we'll discuss it another video, but now learn in sick days you should stop it. Okay, and also some other drugs that needed to be cautious when we are sick, especially in the CKD patients. Second problem is potassium level. If there is hyperkalaemia, if baseline potassium is more than 5.5, you should not give this drug. Okay, that time it should be stopped. You should monitor, and that after that start. And if it is becoming more like in when you are giving treatment with these drugs and you see that it is above 6 or getting above 6, then you should reduce the dose of the drug. Okay, but there are also other ways you can reduce the potassium level in other ways. Then you will keep in mind about reduction the drug. It should be the last resort to stop this drug. Obviously monitor cautiously, and this drug is very much also important as I have mentioned. Okay, so now in third point we will learn how to treat the complication, the most important, because you monitor the disease, you have treated the what can reduce the progression by maintaining hypertension, proteinuria, you have halt the progression. Now there will be complication of this disease. How you will manage? Let's come to the point. So what are the points? Number 1a, there will be a fluid and electrolyte management. So which type of fluid and electrolyte will have problems? As I have already mentioned, there will be problem of potassium. So you will be very much cautious about potassium. You will try to maintain the target of 70 millimole. You will try to keep it below 70 millimole daily intake, and you will be very much cautious about taking foods that are potassium containing foods. I will discuss in another video which type of foods that are very much rich in potassium. Some fruits are there, vegetables are there. Those patients suffering from CKD should be cautious about those foods, and they should restrict their food intake. Okay, now secondly, after dietary restriction, you have restricted by diet. Now the question is how we can also reduce it, this potassium if becomes more in the body. So second point will come the potassium binders. Those potassium binders, they bind the potassium in the gut. some of the drugs names. These are resonium, that is a calcium resonium. It is not now indicated, but in some countries, some previously this drug had been used, but this is now not used, and it caused the bowel necrosis. Okay, so it's for side effects, it is not now used. Again, important drug that are used, that is sodium zirconium cyclosilicate and Proteinuria. This is the name of the drug. You must keep in mind sodium zirconium silicate and Proteinuria. These are used as the potassium binding drugs. Okay, and another way you can also reduce this by sodium bicarbonate, that will help to reduce the acidosis. So when there is acidosis, you will control the hydrogen ion in the body. It will also control the potassium. So and also you should be considerate about the drugs that already I have mentioned, AC inhibitors and ARB. So these are the methods like potassium dietary control, potassium binders, controlling acidosis. After those things you will consider this AC and ARB, but definitely if the level of potassium is very much, you will already start above treatment and monitor the level and be considerate about the use of the drug. Now we have mentioned about potassium. Now what about the sodium and fluid? Those two things also increased in CKD patient. So very much easy, restriction, salt restriction should be, sodium restriction should be less than 100 millimole. It is sodium restriction. Also fluid, if there is edema, then we will also reduce the fluid intake. Diuretics can be used in thiazide, it may be loop, thiazide, or combination. Another option is another disease. Sometimes this sodium and fluid is not only excess in diseases like causing CKD, tubulointerstitial disease, the sodium reduces as salt wasting disease. It is known, salt is gone through the urine. So this is salt wasting disease, sodium reduced. So in treatment you have to give sodium. Okay, so this is how you will maintain fluid and electrolyte. Another things, especially protein intake. Unless severe case, protein restriction should be given, as this protein will accumulate as urea, which is toxic to the body. So in CKD patient, protein restriction should be given, but not excess, that may cause malnutrition. You should keep in mind whenever you are treating something, there are something we always still keep in mind. So don't do excess, it will cause malnutrition. So now another complication after fluid and electrolyte management, another problem that created here, that is fluid electrolyte. I have mentioned about fluid and electrolyte A and given its treatment. Now it's B, it's acid base balance. So what happens? The hydrogen ion concentration increases as kidney cannot excrete it from the body. So you will give treatment sodium bicarb. Very easy. Sodium bicarb, and you have to maintain target more than 22 millimole per liter. Sodium bicarb 3 times 1 gram. It is usually practiced 1 gram 3 times a day. Okay, so this is important what I have mentioned. Most importantly, plasma bicarbonate. There is nothing excess drug. The mechanism I will not discuss here, in another way. So another complication are renal bone disease, very much important. This topic, it's itself is a big topic, how this renal bone disease occurs, and there are different types of phenomena going on in CKD into the bone. But two main thing in treatment purpose, you only keep in mind that there is excess phosphate, and you will treat this excess phosphate level. So in diet you should not restrict the taking of milk, cheese, eggs. Okay, in some protein rich foods there should be restriction should be there, as this will increase the phosphate level. And another is a binding drugs like potassium. There is also another binding drugs there. So what are the names of these binding drugs? Very much important: calcium carbonate, aluminum hydroxide. Okay, then lanthanum, that's the newer drugs, lanthanum carbonate, polymer based binder. So there are many options in your hand for binding of the phosphate. Okay, the target should be below the target here, below 1.5 millimole per liter. So phosphate increases. Now as vitamin D is not produced due to CKD, active metabolism of vitamin D, you will give vitamin D, that is 125 dihydroxy D, vitamin D. Okay, vitamin D, active metabolite of vitamin D, it should be given, but care should be given, care must be given, again care guys, care must be given. Calcium should be less. Okay, the hypocalcemia must be there, and PTH level must be 2 times from the normal level. Okay, if you don't do this, what will happen? And a special disease will occur. It is called Adynamic bone disease. It's another complication related from the treatment in renal bone disease. So it's different discussion, but you should keep in mind these two things. Okay, one is the calcium level is low and PTH level is more than twice of the level. Now in phosphate, vitamin D, in some diseases, in renal bone disease, there is a stage where there is tertiary hyperparathyroidism. PTH level is more and more and more. It's become autonomous due to the problem of CKD. For that reason, you can operate the parathyroidectomy. You will remove parathyroid, so the problem will be gone. Okay, and some drugs are there. It is called cinacalcet. These are the calcimimetic drug. They bind to as act like calcium and bind to PTH glands, parathyroid gland. They bind to parathyroid gland and reduce the secretion of the PTH. Okay, cinacalcet. It's another thing's name is calcimimetic drug. Okay, it acts like calcium. It's calcium is bind to PTH, and then PTH sense that no need of excess parathyroid hormone secretion. No problem, there is enough calcium, so PTH level is reduced, and that will give us the proper treatment of excess PTH in the body. Another complication, important complication after acid base balance, fluid electrolyte imbalance, acid base imbalance, renal bone disease, and it is anemia, very much common, those who are anemic. But treatment is very easy. You will correct the iron level. Okay, so you will give iron, you will correct it the iron level. After giving iron, your target will be, always keep in my target 10 to 12 gram per deciliter of hemoglobin. You can give EPO, erythropoietin level, but if you give early erythropoietin level, unless you corrected the iron level, this will not work. Okay, so you will give erythropoietin later, so the you can avoid giving excess blood transfusion. So always keep in mind about giving iron deficiency treatment by iron and erythropoietin. Now last another now treatment. So these are the complications I have mentioned. Now number four now comes the treatment of risk factors of cardiovascular disease. Now what happens, this CKD that causes more and more cardiovascular disease prompts, as calcium plays an important role here. This calcium deposits in different blood vessels, and that causes atherosclerosis and increases the mortality of the patient. So you will only try your best to treat the risk factors of the cardiovascular disease. These are very much common risk factors we all know, like lifestyle management. Okay, you will do exercise, weight loss, no smoking, very much common thing, alcohol, lipid lowering drugs. This will reduce the cholesterol level in the body. Okay, if you maintain these things, there will be your risk factors of CVD, cardiovascular disease, will be gone, or will be treated, and that will help. As you have existing CKD, this will reduce your mortality rate, or the impact from cardiovascular disease. Now the last but not from the list, you have to ultimately prepare the patient, because it is a progressive disease. We monitor the patient, we halt the progression, we give different treatment of the complication, treatment of the risk factors, but you should prepare for renal replacement therapy. Now what are the renal replacement therapy? There are different type of renal replacement therapy, that is dialysis, and another one is the transplant, renal transplant. Now dialysis is hemodialysis and peritoneal dialysis. So you would prepare the patient for renal replacement therapy by early referral to the nephrologist. It will determine the need of the patient about RRT and which type of renal replacement therapy is needed. It will be easily determined, and it will increase his outcome. So it is told that 12 months before the preparation should be started. There, in this preparation, psychologically you have to educate patient about the disease. There sometimes psychologically patient broke down, he suffer from depression. So it's a multidisciplinary approach should be there for the patient about the education. And now physically you have to do the access for dialysis, like the access of catheter, okay, and other preparation plus vaccination against hepatitis B. It is more common that patients suffer from hepatitis B and C due to dialysis. And there is also a target in renal replacement therapy, as different type I have mentioned the target. It is varies from patient to patient, but 10 milliliter per minute if eGFR it is the target. So 10 is the number you will go for renal replacement therapy. So guys, I have discussed many things, but now have some easy PG discussion. So at first you will monitor the renal function, monitor the renal function. You can use a graph in 6 monthly monitoring for stage 3 CKD, more frequently stage 4 and 5. Then reduction of the progression, treatment of the primary cause, treatment of the blood pressure, proteinuria. Always keep in mind ACE inhibitor ARB, target BP in CKD, no albuminuria 140/90, but diabetic and proteinuria 130/80. Okay, treat the complication, fluid and electrolyte balance. If potassium overload, target should be 70. Give potassium binder like sodium zirconium, patiromer, sodium bicarbonate. By treating the acidosis, you can reduce the potassium level. ACE inhibitor stopping or reducing the dose is another way. Sodium and fluid, it also can also become excess in the body. You should restrict it. Like potassium, dietary restriction target 70, but sodium it is 100 millimole per liter. Then the diuretic you can use loop diuretics and combination. Tubulointerstitial diseases, it is also in those diseases there is the salt wasting, so sodium will be reduced. Then you have to keep sodium. It's different types, but keep in mind also. Okay, then protein intake, protein should be restricted but not severe, otherwise it may cause malnutrition. For why? To combat the excess urea level. Acid base balance, the complications, hydrogen ion etc. reduces by give a base, sodium bicarb. Renal bone disease, what happens? Phosphate cannot get out of kidney in CKD, so restrict by diet, give binders so that they cannot be absorbed. Calcium carbonate, aluminum hydroxide, lanthanum, polymer based binders. Here targets is less than 1.5 millimole per liter. Vitamin D cannot be activated, so you give activated vitamin D. Vitamin D, but care should be hypocalcemia there must be there, and PTH level more than 2 times. Okay, if PTH become more and more in complication, then you can do parathyroidectomy, or if you want to give conservative treatment, cinacalcet is a calcium mimetic drug. It reduces the PTH secretion. Okay, thank you very much. Anemia, anemia treatment. Iron deficiency common, give iron. After giving iron, target 10 to 12. Then iron is maintained, iron level is good, then you can go with erythropoietin. Okay, the treatment of the risk factor of the cardiovascular disease, not confused with cerebrovascular, it's cardio. I have lived in the short form. So what are the risk factor of cardiac disease? Lifestyle management, do exercise, reduce cholesterol, stop smoking, reduce your weight. Okay, And last but not the least, prepare for RRT, renal replacement therapy. It may be dialysis, it may be transplant, hemoperitoneal. What the patient needs, that will be directed by the nephrologist. That, the preparation should be 12 months before. Psychologically he should be prepared by education, and physically there should be access for catheterization, for dialysis, and vaccination should be given. I think I have tried my best, my friends, to cover the management. Just here, listen the video and go to your book. You'll understand now more and more easily. There are some other things, the mechanisms I will discuss in other videos, but these are the core management. Thank you very much. Thank you guys for listening again. Please subscribe the video.